Hi, everyone. We're just letting all of the folks come into the webinar, so we'll be starting in about 1 minute. All right, well, good evening and welcome. I'm Diana Robbins. I'm the director of the AJ Drexel Autism Institute. As the first autism research center in the United States to focus on the public health science of autism, our mission is to pioneer research to better understand autism and drive impactful change. Today, we are not focusing on our own research. We've come together tonight because autism is once again at the center of national conversations, with new claims raising real questions, and in some cases, renewed fears. Over the past week, we've seen headlines about autism and Tylenol, vaccines, and leucovorin, a medication used to reduce side effects of chemotherapy. Families are left wondering what's true, what's not, and what it all means. We're here tonight to try to address some of those questions. One of the things we'll talk about tonight is the difference between correlation, two things that happen together, and causation, one thing causing the other. A simple way to think about it is this: ice cream sales are correlated with shark attacks, but it's not a causal relationship. If you ban ice cream sales, you won't reduce shark attacks. The same caution applies when we see scientific studies that find correlations. We have to design experiments specifically to determine whether one aspect truly causes the other, or whether something else might explain the connection. Our goal tonight is to separate evidence from speculation and give you the facts to guide your decision-making. I'm joined tonight by three incredible panelists: Dr. Dina Gassner, an autistic scholar and advocate who brings the essential voice of lived and professional experience; Dr. Diana Schendel, an epidemiologist and global leader in autism research; and Dr. Matthew Lerner, a clinical scientist focused on interventions and outcomes. We'll start off asking each panelist to introduce themselves, and then we'll go right into the discussion. Dr. Gassner, can you get us started, please?
Sure. Thank you so much for having me. I am currently working in the lab with Matt Lerner as a senior research scientist here at Drexel. I'm the odd duck. I'm not a psychologist. I'm a social worker by training. And I've brought to the table 25 years of systems navigation, clinical work, and helping autistic people transition who have received a very late diagnosis and are trying to understand life differently. I served one term on the IAC. I have one term left to serve, and I spent 8 years on the board of directors for the ARC US. I'm currently on the board of directors for the Institute for Exceptional Care, and my current research is focusing on systems navigation approaches and many other things that we do here at Drexel.
Thank you. Dr. Schendel, can you introduce yourself, please?
Oh, sure. I'm the professor and leader of the Modifiable Factors in Autism Epidemiology Research Program at the Autism Institute at Drexel. I come to the table with 25 years working in autism epidemiology as well as other developmental disabilities. I actually started my research in autism when I was at the CDC many years ago. I was part of the CDC team that launched the ADAM network, the Autism Prevalence Network that's across the United States. I also was the science lead for CDC's large multi-site study looking at autism epidemiology. And at the same time as I was doing that, I was networking with researchers around the world, doing a lot of multi-site studies in autism epidemiology. And I've really been across the whole spectrum of autism studies, everything from risk factors to prevalence to gene environment interaction and so on. So I really have a broad view of the history of autism research, really since the beginnings of autism epidemiology on a grand scale.
Thank you. And Dr. Lerner?
Hi, I'm Matt Lerner. I'm an associate professor and leader of the Life Course Outcomes program here at the AJ Drexel Autism Institute. I also have about 25 years of experience in the field, including originally working, developing a nonprofit program to try to meet the needs of autistic kids and teens and their families, trying to really listen to the priorities of the community. Then for the last 15-ish years, run a research program here and previously at Stony Brook University, where I was the research director of the Autism Initiative, focused on trying to understand what success looks like for autistic people, social success, professional success, a sense of well-being, and really ultimately life course outcomes. Our interest here in our team has spanned looking at mental health conditions and concerns, looking at different ways of trying to make interventions reasonable and accessible, and has ultimately involved really, again, trying to figure out, how do we listen to what the priorities of the community are, which makes me especially pleased to be here today because we are hearing so much from the community that this recent news brings up a lot of concerns and questions, and hopefully we can be here to answer some of them for you.
Thank you. So just a few housekeeping comments. We invite you to submit your questions during the panel using the Q&A function. If anyone's not familiar with Zoom, you should be able to see down on the bottom of your screen a little question mark, and below it says Q&A. If you click on that, you should be able to submit a question to the panel. I know we're not going to be able to get to all of the questions. We also have a few that were pre-submitted when you registered. So we will be preparing and sending out an FAQ document with answers to more questions than the ones that we can get to. We also plan to share the recording from this session. So I hope that you get your questions answered today. So without further ado, Dr. Gassner, the first question is for you. There's a dark history of blaming mothers for their children's autism. Sadly and frighteningly, it's coming up again now. What would you say to all of the mothers and other caregivers of autistic individuals?
Thanks so much, Diana, for this opportunity. So I come here wearing a lot of different hats. I am an autistic scholar. That means I got diagnosed very late in life at 40. I'm also the parent of a 35-year-old son who was diagnosed at 3. And I have another adult daughter who was also neurodivergent, although not autistic. And the life journey that we've shared as a family has been incredibly challenging. And it mirrors that of many, many hundreds of thousands of other families out there. But no one in our social networks, in our social strata, has been shamed or blamed for their children's differences more than autistic mothers. Actually, blaming mothers for the difficulties of their children is biblical. It goes all the way back in the day. But more recent research has reflected that, in contrast to that, what has happened is mothers have become warrior mothers. They have almost become to the point where they feel like they need to overcompensate to bypass that shaming identity that's been assigned to them. But what we've learned in the research is that these mothers largely exhibit unrelenting efforts to get their kids through these programming barriers that they face. We often give up our employment. As many as 15% of mothers leave the workplace, up to 40% when intellectual disability is part of that. And not only are we losing their income, we're also looking at people who are adding up to $5,000 a year in costs. And I can cite these research sources for you if anyone's interested in them. But 30% of moms and 13% of dads either cut back or have to leave work, not because autism is a horrible, nasty thing, but because of the insufficiency of supports and systems that are just simply not supporting these families. We experience an inhumane, constant demand to not only become experts on our child, but we also have to develop intense expertise in each developmental level that our children pass through. That means we have to navigate early intervention all the way through to post-secondary placements for our children. And that's an incredible demand that's placed primarily on women. We also endure secondary, and then the siblings endure tertiary harm and neglect from a lack of system support. But Sousa says it best. She says, parents have become the most vocal and unrelenting advocates for better access to support services, specialized educational supports, timely and accurate diagnoses, and a wider acceptance of autism as a culture rather than a disorder. The results of this can be very difficult. We've talked about vaccine hesitancy, but we also need to talk about healthcare treatment hesitancy now, because many chronically ill mothers and many neurodivergent mothers who also have co-occurring conditions need pain management during and after pregnancy in order to be able to be on their game when they're navigating all of this with their child. It's the reality of it is we live in a panopticon where the social service systems can see into our lives. They get to know every intimate detail of our lives. But we are standing alone in that panopticon, and we have to be able to navigate all these multiple systems. We also endure a lack of neurocognitive privilege, many cases, in terms of access to education, access to systems navigation, just being able to execute human capital to ensure that our children are well cared for, and at least at baseline safe. We have made these points repeatedly through the years about the need of more and more support. John Robeson and I wrote a commentary just 2 years ago that there's really not a push, an increase in autism diagnoses. There's an expansion of the diagnostic categories that has resulted in many people who've gone decades without a diagnosis finally getting them. And no one endures this more than mothers who are themselves neurodivergent. We have to navigate all these systems with challenges to executive function, with challenges to organizational capacity, with challenges to networking in these systems to know how to navigate them. And so we really need to do better and focus more of our research monies on how we can provide better system support, how we can build an army of systems navigators, as compared to shaming, blaming, and frightening very, very well-intended and persistently dedicated advocates for their children. Thanks, Diane.
Thank you so much. Dr. Schendel, what do we know about Tylenol and autism?
Well, to answer that question, I'd like to lead off with an important point that everyone needs to keep in mind, and that is that genetics are the primary factor contributing to autism. The strongest factor leading to a higher likelihood of getting an autism diagnosis is a family member with autism. And the higher the genetic link between the two family members, the higher the likelihood that the family will have an autistic person. So keep that in mind. The genetic underpinnings of autism is much greater than any other non-genetic factor. So that's the background that we go into the Tylenol story. The Tylenol story has been looked at for decades now, actually for about 20 years. Oh, no, I'm sorry, I'm thinking of the vaccines. But it's the same. The Tylenol story has been looked at in terms of medications for many studies. And consistently, the data have shown some studies have shown a modest or small association with autism, but as Diana pointed out at the beginning of our webinar, association is not causation. The largest study that has been done relatively recently, looking into the Tylenol question and link with autism, actually tried to tease out that causal link. And they used what they were looking at was the risk in families. By looking into focusing your attention on families, you can tease out whether it's a family factor that may be contributing to the link between Tylenol and autism. And when they use this kind of design, that looking at differences between siblings, if the mother took Tylenol in one pregnancy and didn't take it in the other, was there any difference in their the two children having autism, and there was no difference. So they concluded on the basis of this very large study that there was no causal association between taking Tylenol and autism. It's important to remember when you look at these data also, is that you take Tylenol for a reason. You don't just take it because, it's not candy. You take it for a reason. It's because you're having a fever, or you're feeling sick, or you've had an infection. And these conditions that I just mentioned are also risk factors for autism. They also increase the likelihood of having an autism diagnosis. So the fact that the woman is taking Tylenol for a fever means if she has a fever, she's not taking Tylenol, the fever, in fact, may be a risk factor for autism in her child. So by denying the access and use of Tylenol is not removing any further risk. You're exchanging one risk for another. And the risk for autism or risk for other conditions is also elevated by having a fever during pregnancy that's untreated, or having an infection that's untreated. So it really, the fact that we can't identify a causal association, the fact that you would be under some idea that you're being extra cautious, doesn't mean you're really removing any risk. You're actually simply maybe replacing it with something else.
Thank you. I want to just highlight one of the things you said about that large, very rigorous study that looked specifically at siblings. It's a good reminder that not all studies are equal, and that studies that are done with very rigorous design and methodology and very large samples, where they do their best to control for all of the variables that might be influencing the outcomes, are better studies, and we should give them more weight.
Exactly.
All right, Dr. Lerner, one for you. Many parents are eager to try new things to help manage the challenges of autism. What would you say to families who are wondering if they should ask their physician to prescribe Lucavorin?
All right. So let's take a step back for a second and talk about what is Lucavorin and why is it a thing that you would think about at all. So the story starts with something called folate. Folate is a naturally occurring vitamin, B9. It is part of how we metabolize and process red blood cells. It is healthy for cell growth and cell functioning. It is really actually important for development, and it's found in lots of healthy things that you can eat, like oranges and bananas and nuts and beans. And we do know that folate is something that is important, for instance, prenatally for development. In fact, if you are a pregnant person and you are taking a maternal supplement, you probably are taking folate already right now. And actually having adequate folate is important for things like neurodevelopment. Okay, that's what folate is. There have been some studies that have looked at levels of folate in autistic people, primarily children. There are not that many, and they are, to Diana's point about quality, they're not like what you would consider sort of large, high quality, super rigorous studies where we can really sort of pinpoint what the amount of the deficiency is or what it's related to. There's a suggestion related to a genetic abnormality, which is a whole other complicated issue. But regardless, some people say, hey, maybe some autistic people have folate deficiencies. So Lucavorin is, in fact, it's essentially a derivative, or a sort of, you can think about it like a concentrated version of folate. And it's a folate supplement that you can take. Again, it's often given to people when they're in cancer treatment for things like fatigue, to kind of give you a sense of energy. People will often also off-label use Lucavorin for other things, including, I've heard it used to sort of help with low levels of depression or anxiety, things like that. Okay. So then all of those things add together, and people say, well, what about Lucavorin for autism. Well, it turns out leucovorin is one of many drugs that are prescribed off-label or taken off-label for autism in the community and have been for many years. What I'll start with is the anecdotal evidence before you get to the research. The anecdotal response, if you talk to people, is that it seems kind of inconsistent. I know a lot of autistic people who have taken Lucavorin and other folate supplements over the years, and their response has sort of been like, look, it wasn't a magic pill, just like nothing else has ever been a magic pill. But they felt like it was worth a shot. There have then been a few small studies looking at leucovorin, and the results of those have been also not blockbuster. They are inconsistent at best, and several of them showed null effects, or upon careful investigation showed null effects. So, moral of that story then is that the last thing I would say, though, is that leucovorin, by and large, is not considered to have a significant side effect profile, especially if you don't take that much of it. You can have some GI stomach problems. So, moral of the story is don't take medications without your doctor's consultation. If you decide to go to your doctor, understand that the literature on this so far suggests that this is not likely to dramatically change anybody's life. But if it is part of a sequence of things you are considering, understand that it may be one of the things in this sequence of things that you are considering. The last thing I would note about it, though, which is very important, is that none of this research, including the recent federal announcement about expedited FDA approval, gives any guidance about dosage. Right. So there are generally with medications, right, you might say, all right, I'm taking 20 milligrams of this or 30 milligrams of this because that's what the FDA recommendation is, and that's what my doctor says. But that really hasn't come up because we haven't gotten that far in the literature. There's not enough data that any dosage is especially helpful, and even within that, we don't have any information about what levels actually could make a difference for what person. So, caveat emptor is the moral of that story.
And Matt, I would add that given the high incidence rate of co-occurring hypermobility conditions where gastric slowing is problematic, you add that to the constipation of that particular medication, and it could create some really complicated medical interactions. I'm not here giving medical advice. I'm imagining the combinations.
Yeah, thank you. That's a really good point, though, Dina. Thank you.
Thank you. So Dr. Gassner, a question came in that I think is a good one for you. What are some practical ways communities can advocate for funding to support access to quality services for autistic people?
Well, I think it begins with community conversations. We here at Drexel are about to start a project that's going to focus entirely on having difficult conversations about autism interventions. And I think what we need to stop doing is stop looking at the two most extreme points where we have disagreement, but focus in the center where we have agreement. There's no one in the community that can't suggest that we don't need improved educational access, as an example, improved access to community health care as a group. Whether your loved one presents with high support needs, intermittent support needs that ebb and flow, or lower support needs, when they have needs, they need support. They need the services that they want. And so I think if we come together as a community and focus on where we have agreement, and we stop thinking of it as an us-them scenario or a tiny little pie, but we focus collaboratively on building a bigger pie so that everybody gets what they need, whether it's 5 hours a week, 5 hours a month, or 24/7. Everybody needs a little bit, or they wouldn't have the diagnosis to start with. So let's first of all start by having a conversation focusing on where we have agreement, and drive the advocacy from that point of agreement. That would be my input.
Thank you. Dr. Shandell, a question for you. There's been a lot in the news over the last week or two about autism and vaccines. Can you tell us a little bit about what we know, and specifically at some point, if you can address the question about whether it makes sense to split apart some of those combination vaccines like the MMR, the measles, mumps, and rubella? What's your opinion on doing them separately versus as a combination?
Well, thank you. And I think I'd like to start my response. I think I'd like just to remind everybody about the quality of studies, the point that you made previously. Because the opening comment I'd like to make is the first study that brought this whole idea of vaccines and autism connection to the forefront was a very small study back in the 90s of only 12 children. And subsequently, it was discovered after the paper was published, based on only 12 children, it was discovered that some of the data had been falsified. The paper was retracted from the journal, and the researcher was put into in poor reputation. But that got the ball rolling. It was such a startling announcement that the ball was going by the time all of that further information came to light. And since then, actually, I went to look up what's the most recent Cochrane review, which is a very reputable review organization. The most recent review, there were 138 studies of the association between vaccines and autism. 138, over 23 million children included across these studies. And the definitive conclusion, there was no association between vaccines, and including the MMR vaccine and autism. So I think the evidence is pretty strong and conclusive and very consistent of the lack of association between having a vaccine and autism. But there have been other factors associated with that have been raised, such as the antigen load. You know, if you're pumping a lot of vaccines into children at a very young age, that cumulative load may be harmful. But there was a study that looked at that very question, and there was no difference in the antigen load between children with and without autism. So that there was no elevated antigen load from vaccines, for example, associated with autism in a reputable study. There was the question about whether additives such as thimerosal, which is a mercury additive, thimerosal was removed from vaccines, the MMR vaccine, for example, in the United States in 2001, a long time ago. It was removed in some European vaccines in the 1990s. And clearly the removal of the thimerosal from the vaccines has not altered the trajectory of autism prevalence across these countries. Another big additive that's been pointed to is aluminum. The aluminum is potentially a targeted factor that increases the risk for autism or other neurodevelopmental conditions or other childhood conditions. There actually was a huge study published in July of just this past year of 1.2 million children looking at the cumulative dose of aluminum in the first 2 years of life derived from vaccines. And there was absolutely no difference, no effect of the cumulative aluminum dose from vaccines specifically, and the risk for 50 different conditions, of which included autism and ADHD. So I think the evidence seems to be coming in. It's being looked at over and over and over again, because obviously this is a very serious concern. You take a healthy child into your caregiver's office, they punch a needle in the arm, and your child gets sick. And so obviously you're concerned, you don't want that to happen. But the evidence seems pretty strong that there is no association between vaccination and autism. And the question about whether you should disaggregate the vaccine. So the measles, mumps, rubella is an aggregate of 3 different substances to prevent each one of 3 diseases. So why not break them up and give them one at a time to prevent an overdose, antigen overdose in one fell swoop? That's potentially, technically, that's possible. But the real problem with that, and this has been carried, the solution has been over many, many years of study and how people get vaccines, how people raise their children, and how often they go to the doctor, and what prompts them to go to the doctor, and when they can get the vaccination. And in those instances, you run the risk of a vaccination being missed. People get busy, a child gets sick, you can't make the appointment, and therefore you have a delay in getting your different shots. And when you do that, you're running the risk of your child getting the infection for which the vaccine might have prevented. And those infections do, in fact, have an increased risk for a whole host of health problems that, or even very, very serious ones that could potentially even lead to death. So, well, whereas technically you could disaggregate the different vaccines and give them spread out over time, at the time you're exposing your child to the potential for getting one of these childhood illnesses, which can be quite serious. You wouldn't think about tossing your child into a swimming pool with only half a life preserver. And this is the same kind of idea. It's a package, and you're giving foolproof protection against a very serious illness by giving the combination.
Thank you. Dr. Lerner, for you, I'm going to actually expand a little bit on one of the questions that came in through the Q&A. The question originally read, how can we best respond to more clinical colleagues prescribing Lucavorin, maybe not having as strong a research background to understand the nuances, such as which journals are predatory and not undergoing rigorous scientific peer review, or which studies might have conflicts of interest that are clouding the interpretation of the findings to best interpret the research. And I would sort of expand that a little bit, excuse me, to also say, what can we do to combat public opinions that go against scientific evidence?
Sorry, I was having trouble unmuting. Which is perhaps a metaphor for how we try to get get the word out. Sometimes we can be muted by other voices. I mean, I think for the most part, most people, I say most people are not interested in the fine distinctions between different types of research journals or where they come from. And I say this as somebody who's very interested in that and spends a lot of time, thinking very carefully about whether or not the work that I'm doing constitutes good science and the work that I'm reading is rigorously done. I think that the best thing that we can do as both whether you're a scholar or an advocate or a family member or a clinician is to, one, look to the types of comprehensive sources that, like Diana Schendel mentioned, right, like the Cochrane reviews or other kind of major reviews that kind of incorporate that information into their review process. They review these articles often with kind of weighting them, almost giving more weight to ones that are more rigorously and carefully done. That's a good kind of high level way to look at this information, to gather that information. Another is to look to reliable, reputable sources. I would point to the Autism Impact Report from the Policy and Analytics Center right here at the Drexel Autism Institute, which does an excellent job putting out annually and sometimes more frequently really thorough, digestible, accessible information to the public about key issues in the autism world, and making sure that you are relying effectively on that, and then ultimately to the degree that you are somebody, the questioner is somebody who's in a position where you're like you are thinking about this stuff or evaluating rigor, you can be a spokesperson for good rigorous science. In fact, I think the only way that we end up sort of unmuting ourselves in a space and a time where it's so hard to be heard is to make sure that everybody who's in a position to be an effective advocate, who has access to good knowledge, who has access to resources like this presentation, that you help to share that out, so that true information wins the day.
Thank you. Um, there's a question that says that there was some reference in the news to a cultural or religious group that does not have an incidence of autism. And what could the panel say or reflect about that claim? I'm not sure if somebody wants to volunteer to take that one. Go ahead, Dr. Lara.
All right, I'll get it started, although I would love to get thoughts from my co-panelists about this too. So the discussion was about, the comment was about specifically, I believe was the Amish community having, there was a statement that they had little, or I think the statement even went so far as to say no incidents of autism. First of all, there was also a statement about the country of Cuba. We have, in as much as we have epidemiological data from those spaces, that is not the case. There are, in fact, autistic Amish people. There are, in fact, plenty of autistic people in Cuba. By and large, although, again, I'll defer to Dr. Shendel on this, the research to date suggests that the rise in autism that we see, or the levels of autism that we see, is in all of the places that we look for it. And the reason you might see a difference, though, is that the primary drivers of the rise in rates of autism have to do with awareness among diagnosticians and among people in the community to go look for autism, and changes in diagnostic criteria where we have a much broader spectrum. The second one's a little easier to get your head around, right? 30, 40 years ago, there were only a couple of ways to have autism in our formal diagnostic Bible, the DSM, and they generally involved having really pretty substantial communication challenges. Whereas now we had something called Asperger's for a while. Now we have a sort of broader understanding of the spectrum where folks can go, as Dr. Gassner said, 30, 40, 50 years and not necessarily get a diagnosis until perhaps the social or other demands of an environment lead somebody to go seek one. So that's our category changing. But it really is the awareness piece that makes a difference, right? Clinicians, 30, 40, 50 years ago were not being told about what autism was. I used to talk to a friend of mine who was a primary care physician, a doctor. It was trained in the 70s. And I said, did you ever learn about autism in your medical training? And he said, yeah. On the fourth day of medical school, fourth year of medical school, the last day in a class called, here's a bunch of things you're never actually going to see. And they listed about 20 different sort of super rare conditions. Well, that doctor then going into practice, understandably, is not going to necessarily have an eagle eye out for that information. So if there are, if that has not been disseminated out into certain communities, if that information is not out there, you're going to see different rates. Likewise, in communities that are, for instance, not necessarily accessing or seeking the same either health or public education services, which are often the ways people find their way to a diagnosis, then those kids are not necessarily going to get a referral. So the moral of that story is, in these communities, even if we saw a difference in rates, it's not that the kids are not, or adults are not out there, but they're not necessarily engaging with the systems that would bring them to a qualified clinician to provide a diagnosis in the first place. Dana? Dr. Gassner?
Yeah. I just wanted to add to that also that seeking an autism diagnosis occurs when a person hits a pivotal moment in their life when they can no longer cope. And I can say that in more rural areas where the work is more driven toward manual labor, where the tasks may be less multi-layered, where the demand for socialization may be diminished, that can reduce the number of people who are autistic that get identified, as compared to being in a large urban area where people are trying really valiantly to seek employment, but the employment demands far exceed what their capacities are. For me, my personal wall was having 2 neurodivergent children and a husband who never slept at night. And it was the sleep deprivation, the chronic sleep deprivation, that led me to seek a diagnosis in my 40s. Up until then, although I struggled relentlessly, I was able to somehow just claw myself to the top of achieving whatever goals I put in front of me. But after that point, everything fell apart for about 15 years. And a lot of that was related to misdiagnosis and harmful treatment that occurred from the misdiagnosis. So I would think that we need to look at the regional, cultural, environmental areas before we can actually compare numbers and project that, you know, a more rural natured community might have less autism. It may be that they just have less demands on the individual, resulting in fewer diagnoses. But if you did a cross-cultural sample of everybody in community, you would find us there. We've been around since a tale as old as time.
Thank you. You make a really important point. Having a diagnosis is different from having the symptoms that could lead to a diagnosis if you were in front of a clinician with expertise. And there was actually a study not too long ago that showed that even as diagnoses are climbing up and up and up, if you look at the symptoms that parents are reporting about their children, it's fairly flat. And so what's changing is the recognition. And actually that leads me into a question for Dr. Schendel. It's thrilling to me that we have someone who was instrumental in starting the autism surveillance program here in the United States. And for those of us who are scientists and who are keeping up with those numbers, we scrutinize each and every report as it comes out. There was a question in the Q&A specifically about high incidence of autism seen in California, but I was wondering if you could talk just a little more broadly about the increase in the prevalence of autism and also some of the variability that we see across the different sites that do contribute to those CDC studies.
Yeah, yes, that's a great question. If you go through the CDC, the records of the CDC reports for the last 25 years, you'll see a steady increase in the overall prevalence. And those are based on usually 10 sites, 12, 15 perhaps. So it's a large number of different places across the United States that are gathering information on autism in their regions. But overall, you see this steady increase across time. But if you open up the package and look under the hood, you can see that there's enormous variation across different areas of the country. And California, for the years that California has been a site, it very typically had a very high prevalence. Whereas if you're comparing it to other states, such as Arkansas or Texas or Florida, even perhaps, it could be a lot lower. It's not that we think that there's a true difference between these areas, but that the level of services that are being provided in each one of these different areas is different. The CDC surveillance system is based on records in schools and in medical facilities. Not all sites can access the medical records, or they can't access the education records. They can't access them both. They can get one, but not both. For sites that have both kinds of medical record, both medical and education records, you get a higher prevalence because you're tapping into a larger group of individuals who are seeking services in a variety of different ways. And therefore you get a higher total number. For those that only access one form of those records, such as the medical records, you don't get as high a prevalence. A recent study that came out from the ADAM network was also very, very important. They were looking at the characteristics of children over time who were getting, that they were identifying in their autism surveillance program. They were looking at adaptive functioning, that is how well the children were able to adapt and cope and carry out their daily activities. And if you can rank that adaptive functioning in a variety of different ways, and then moderate, mild, severe, or higher. And if you look at the characteristics of children in the ADAM data across the United States, across time, there's a very different prevalence depending upon the level of adaptive functioning. The children who had less of a challenge with their adaptive functioning, it was those children where we're seeing a higher and higher and higher prevalence over time. For children with very high support needs, probably had intellectual disability, and other very high support needs, that the prevalence of autism in that group of children has not changed that much over time. So that the ability for clinicians and educators to identify children with autism who have those high support needs has not changed. Those children have been evident systematically in the same way over time. It's the children with less of a support need, which are more likely then to be identified more recently with the added awareness, with the added diagnostic tools, with the added screening tools that we have. It's those children who have slipped under the radar in the past are now being identified. And it's that subgroup of children with autism that have been more likely to be identified over time. And so that's just another indicator of the awareness issue that Matt mentioned, that it's that kind of child that is more likely to be identified today than they were 25 years ago.
And can I add to that? That's one of the critiques that we've continued to relate, is that these are 8-year-olds, and most people assigned female at birth do not get identified by 8. So we see another big push in middle school, another big push for people assigned female in high school, and then again when they leave for post-secondary programming. And then when you have kids, as it was the case for me.
Actually, yeah, you do. If you monitor the rate at which new individuals who are identified with autism between boys and girls or males and females, based on sex assigned at birth, you get a very different rate by age. With the boys, it's very rapid at a very young age. With girls, it's generally nowhere near as high, but you hit adolescence and it goes right up. So there is a clear sex difference in the ability to detect, refer, and get an autism diagnosis based on the characteristics of the child at different ages. That's a very important point.
Thanks. Dr. Gassner, I have a question for you from the Q&A. What is our role as healthcare providers in eliminating stigma of autism to avoid fear of a diagnosis and the fear of vaccines simultaneously? What is our role in social media?
Well, I'm glad you asked me that, because I was just wondering if I was allowed to answer it or if I should wait for the FAQ that's coming out next week. But let me first say that I've been grieving, along with many of my other autistic peers and many of my non-autistic colleagues who had learned almost everything they knew about autism from going to conferences. And we found our community and we found our culture there. And that's where we networked, and that's where we learned that we weren't the only one who didn't like our food touching or whatever our particular scenario was. We weren't the only ones not sleeping all night. And it was from that community that my entirety of identity was constructed, and that of so many others. And so I would say, even at the regional level, do whatever you can to present those in-person events. We're still trying to rebuild after COVID, but people are hungry for community and they're hungry for network. And although social media can go a long way in closing that gap, it is not the same as being able to communicate with people in real time. And that actually goes back to the other question, Diana, about how do we engage in community activism? How do we close the gap between the parents and the adults on the spectrum? I think that's the answer. I think from the regional level, at the state level, at the national level, at the international level, we need to put more people in a room together. As Matt likes to say, in the room where it happens. So we're going to give a little tribute to Hamilton there, but all to say, I think it's really important that we find community. I'm grateful for social media. I think it's really helped a lot of people who may even be too socially isolated or too socially anxious to go into a conference like venue. But I do think that it can also be filled with a lot of misinformation, which is why we're here today, is to clarify a lot of misinformation that's been presented on social media.
Thank you. So Dr. Lerner, here's one for you. The tone of the recent announcements insinuates that autism should be cured. How can researchers, families, providers, and community members shift the conversation away from this and towards supporting the autism community to access services and supports?
This is such an important question, and again, I think one I want to bring to the panel more broadly. But I think as somebody who really focuses on doing work that is meant that is for trying to help autistic people in their families in the world right now, one of the best things that we can do is reduce the stigma that exists around autism, right? This idea that, and I do worry about some of these recent announcements, sort of starting from this premise that autism or having a child who is autistic or being autistic is something to be feared. It is something that can be hard for many people, and is hard for many people, and it's why we have diagnostic systems and supports around it, for sure. But the idea that that somehow that makes autistic people less people or less worthy or not able to be valued contributors to our communities, to our societies, to our schools, to our workplaces, to our families, it's a real problem if we perpetuate that idea. So I think one of the best things we can do is make sure that we're starting from the human perspective, and saying, and think about, what do you know anyone who's on the spectrum, right? A lot of people are now there is much more public awareness. There are media representations and examples of people who have struggled but been successful, and make sure that we are focusing the attention on the millions of people who exist in this country right now, who are autistic and also maybe want some help, or perhaps just want to be heard and understood and respected. Which I guess brings me to the second and perhaps more important answer, which is we should then spend some time making sure that our work listens to and prioritizes those perspectives of autistic people. Because if those are the priorities that are coming out and people understand that, then that also helps to validate and remind people that yes, autistic people have vital, and in fact, in many cases, the most vital perspectives for us to include when we're trying to do this research. I think it's also important, the last thing I'll say, is that we do this with an eye towards understanding the cultural differences in the ways in which autism can present, and the ways in which different families and individuals will respond. I'll note helpful comment from our clinical director, Dr. Elizabeth Sheridan, who in the chat, who said has great things to share in the future about diagnosing, for instance, in central Pennsylvania, and the understanding the differences between the Amish community and the urban communities, and that my hope is that in future we can continue to do work, including in spaces like this, to increase awareness of those differences.
Great, thank you so much. So I wanted to just remind everyone that we knew we were not going to be able to answer all of the questions in this very short hour, but we are planning to put together a document that we will send out to everyone who registered for the webinar. I know that there were a couple of requests for references for some of the papers that our panelists talked about, and we are happy to include those as well. And finally, we will be sharing the recording from this session if anybody wanted to go back and see part of it again, or perhaps suggest it to one of your friends or colleagues. So just to wrap up, I would first of all like to thank you. I know 5 o'clock is a tough time to gather, and a lot of people came out. I invite you to stay connected to us here at the Autism Institute. We have an unwavering commitment to conduct and share rigorous science that helps families and autistic individuals thrive. So please consider signing up for our mailing list or making a donation on our website. The QR code should take you to the donation page, or following us on LinkedIn or Facebook, your social media of choice there, or just checking out our website every once in a while to see what's new. Again, thank you so much to our panelists. I'm thrilled that you shared your expertise with us. And thank you to everybody who came and listened to us tonight. Have a good night, everyone.